So we are seeing various situations, and in that example of that hypomaniac, we have seen that it was not that dangerous. Then mixed one, here it can need hospitalization. It has both major depressive episodes and manic episodes, and it occurs nearly every day for at least 1 week period. So that is mixed one is also needs an hospitalization, and rapid cycling is there. So that is major depression or manic episodes in 12 months for major depressive or manic. Now what major depressive means? Again making almost suicidal attempt or too much low for a long period of time. Or maniac means again very aggressive, almost abusing people, or can cause loss to people like that. This will call as a rapid cycling, and in that case also we need hospitalization of patient. Now we have seen already treatment for major depressive, that we can start with one treatment, any antidepressive agent like fluoxetine or SSRIs or SNRIs or mirtazapine like agents, and we can augment it with any agents, may it be lithium, may it be another agents, and that can be useful. We have seen it in earlier one. Now what has to be done in manic episode? So we shall see various situations. We can check about what are the signs, symptoms are there. Already we have discussed various signs, symptoms which are responsible for maniac, which are to what we categorize as a major depressive, to which we can categorize as maniac episode, to which we can make it as a hypomanic or mixed episodes. Now once we understand about it, we can check all the history, and then we'll go for treatment. So what are our goals of treatment? What we want to do with this? What are our expectations? So we want to eliminate the mood episodes with complete remission of the symptoms, particularly if it is an acute case where the patient is very agitating one, very hostile one, and there are chances, you might have seen in TV serials or some movies that people has to confine to either chains or something like that. These are very severe situations. So these are the various extreme moods, or they have to be kept in continuous observation. And particularly if these are bipolar, then in that case even one has to take care that nothing is available. If they are confined, then nothing is available for their suicidal attempts. Okay, so these all care has to be taken care. So goals of treatment are what? We have to eliminate the mood episodes with complete remission of the symptom. We have to prevent the recurrences of relapses of the mood episodes. Then we'll call it as a continuation phase. So in acute phase, if the patient is hospitalized, our aim is the patient should go back, and in next is in continuation phase, our sort of prophylactic or sort of what we can say sustainant therapy, so that patient will be remaining in that particularly good mood, or euthymia as we have described earlier. Then return to complete psychosocial functioning. Then we want to maximize the adherence with the therapy, because this is actually most challenging job is this, because we know treatment, it is not a problem. The problem is to keep the patient on treatment, because we know if the treatment is stopped in between, we call it as a non-adherence or non-compliance, then it can be a big problem. It can cause relapse, it can cause a reversal of the symptoms, and sometimes these are dangerous. These are dangerous in what sense? Is they will not be allowing now the drug which were earlier active, they may not that much active then. So we have to maximize the adherence to the therapy, minimize the adverse effects, and we have to use the medication with the best tolerability and fewest drug interactions. We have to see that our goals will be again to treat the comorbid substance use and abuse. Here abuse is very important, because we have seen that abuse are related. These are all abuse. this marijuana, heroin, and all these kind of, we call them as a substance of abuse. So all these substance of abuse, we have to see that person is not taking it. Otherwise, we are going treatment for mania and all, and the person is taking cocaine or any opioids or heroin or other substances like triphenylate, and there are many substances with different mechanism of action and different type of effects, like hallucinogen, etc. If the patient is taking them, then your whole treatment can fell down. So you are checking it, what are the comorbid substances are there and what are the abuses are there. You have to control it, eliminate the alcohol, marijuana, cocaine, amphetamine and all other treatment, minimize the nicotine use if the person is a cigarette smoker, and stop caffeine intake as at least 8 hours prior to the bedtime, because it will cause CNS stimulation. Already here in maniac people, it is already more excited, and with caffeine it will be more excited. They will not feel sleepy or they will not get sleep, and in that cases, because of sleeplessness, we have seen sleeplessness was one of the reason in the problem. So these are all situations. Then avoid of the stressors of the substance that can precipitate an acute episodes. So there are some issues which can anger, which can provoke the thinking, which can provoke. So if it is known, then this should be avoided. If we know that person get irritated with one or other thing, then as far as this should be avoided, because irritation again is or that irritability can cause provoke in the overactivation of central nervous system, as happens in mania, and then that could precipitate into acute attack. Then one should monitor for the mood episodes, document symptoms, that is on the daily mood chart. Make it just like in blood pressure or in other situation in asthma. People can make their own chart that what was their outcome, what was the blood pressure, or diabetes people, they make their own blood glucose chart, particularly those who are having glucometers. So similarly, they can the chart can be made for the documentation of symptoms on the daily mood charts, on the stressors, that on what issue the person got. If you remember, you might have seen in asthma, people ask you to make a chart that what was the food which which caused more bronchial asthma. So you can determine the allergic substance, and accordingly you can control it, so that next time the person should not be taking that or any medication which has caused. Similarly, here we have to do is when we are making make the stressors, that which are the stressors are there, which are the substance which causes irritation, which causes hyper irritation, and therefore this should be avoided. This issue, this topic, this subject, this type of food, this type of clothes, this type of basic thing which makes the person angry should be avoided. Then make which type of episode occur with what kind of consequences, whether it was depressive episode, whether it was maniac episodes, and accordingly it was there. It can be monitored length of episodes, and accordingly we can match it with the treatment, pre-treatment, post-treatment, or with the period of the treatment, monthly, yearly. If these charts are there, that will be valuable for documenting the patterns of the mood cycle and outcome of the treatment. Both it will be giving whether the whatsoever goal we have set, whatsoever outcome we have planned, whether these are occurring or not. Medication adherence again has to be monitored. Maybe despite all these efforts, if somebody forgets, then what will be the outcome, whether because of that what has happened, that can be checked, and the efforts should be made to avoid it as much as possible. Check for adverse effects, because we know most of these drugs are their own adverse effects. Whatsoever drug we have seen may be lithium, and particularly we have seen with the lithium that lithium cannot be having more concentration, or if when in 5th year you will go for this clinical pharmacokinetics and pharmacodynamics in therapeutic drug monitoring, you will find that lithium has to be monitored. Its plasma concentration has to be monitored, or whether, I don't know whether it was covered in this lecture series, was there in HESDAR, BC sir and Maure sir were given in that. Most probably this topic was also there. about the therapeutic drug monitoring. If it was not, maybe they will be covering sometime. So these are the things, that is this therapeutic drug monitoring is required for this lithium, and therefore this adverse effect they has to be monitored. Particularly sedation has to be monitored, weight gain has to be monitored. We have seen weight gain was with olanzapine, if you remember. Olanzapine is the drug, and again olanzapine we shall be seeing with schizophrenia also, because most of the drug will be common antipsychotic drugs which are we are using over here. We will be using same this drug in this schizophrenia therapy. So this is another situation, that olanzapine causes too much weight gain and obesity. Because of that, another complication of hypertension or maybe cardiovascular complications can be seen. So that has to be avoided, it has to be checked. If the patient is getting sedated, then means definitely you have to advise the patient that not to have any important work which needs attention focused, maybe handling machines or driving vehicles, so that they can avoid these accidents which are occurring. Then suicidal ideation or attempts which are there, particularly during that period. So they can, whether they are less or not, and what changes are there. So mixed episodes with severe depression or presence of psychosis, that can be checked, and accordingly we can have this monitoring with this. Now once we understand all this, then what care we can make. Apart from that, we have got many non-pharmacological strategies, like we have seen ECTs earlier, electroconvulsive therapy. I told you that in movies or at certain places we see that people with having too much agitation, we give mental shock, and this is also actually electroconvulsive therapy. As its name indicates, it is actually used for treatment of epilepsies, but however it can be useful. Basic mechanism is very simple over here. Mechanism is what? That we know that all these activities, whether mania, depressions, these are because of the neuronal firings are there, either too much firing or too less firing, or abnormal firing, the firing which should have been there, these are not occurring, and some other firings are going on. So this type of firings are going on, and to avoid this, then what we will do is, if external current is applied, then this external current have more stronger potential than the neuronal potential, and because of that, this all other potential will be synchronized. Same is the mechanism when it is utilized for epilepsy, where there are rapid and unsynchronized high firing of impulses are there, which leads to epilepsy. So same principle it is there. Then high intensity bright light therapy, we have seen that just now, that it is good for depression, but however it can enhance mania. It can be, if it is given in maniac phase, it can be a problem. Then phase advanced sleep schedule, so that person gets adequate sleep. Then partial or complete sleep deprivation, if it is there, then it has to be checked, and it has to be seen that sleep deprivation is not there. In case in depression, we may allow for sleep deprivation. So these are various treatments which are there. Then accordingly we can go for another measures, like that the use of treatment like RTMS, that is repetitive transcranial magnetic stimulation, repetitive transcranial, across the cranium magnetic stimulation. That magnetic these magnets are applied, and these magnets are asked or this magnet are modulated in such a way that it will improve the circulation in that area, and it will change the magnetic field in that area. It will make some magnetic field, and it has been reported to effective in bipolar disorder. Most data include the use of this TMS as an augmentation in the drug resistance bipolar depression. We have seen this TMS earlier also when we were discussing, or we were seeing the slides of augmentation. So these are there. Then one more way is there, that is called as a vagus nerve stimulation. and it can also be useful in that. One more treatment is there which we called as a psychological one, and we call it as a CBT, that is cognitive behavioral therapy, wherein the communication enhancement training, these are various ways by which one can do. These are what treatment, that is here the patient is having counseling, that they are allowed to realize that there is some chemical changes which are there, because of that their behavior is not proper, and whenever they feel that this kind of behavior is happening, they can self control it, they can self try to restrict this situation. So the cognition is there, that is they should understand, cognition is understanding, so they will try to understand what kind of situation is there. And just like if you have somewhere you have read about migraine, in migraine people get aura, they get feeling that now they are going to have an episode of migraine. Similarly, training is given to the people that yes, they can have, they can think about it whenever they are feeling like that, either depression in mood or too much elevation in the mood or mania like situation, then they should try to self control, they should see that they are trying to manage at their own, and this is what cognitive behavioral treatment. Apart from that, adequate nutrition, sleep, exercise, stress reduction, these are various things which can be adding, and removal of various deficiency like sleep deprivation, then other stressor are there, deficiency in dietary essential amino acids, fatty acids, vitamins, minerals, which can change, which can affect the mood, and therefore these all things has to be managed simultaneously along with the pharmacological therapy. So we have seen all these non-pharmacological therapy simultaneously, in which CBT is there, TMS is there, ECT is there. These are physical one. These are the various kind of CBT and TMS and ECT are some physical application of physical mechanisms, while CBT is cognitive or behavioral, or what we can say counseling techniques. Then we can have various agents into that. Many of these we call them as a mood stabilizer. So that these are the medication which are used in the treatment of bipolar disorder, and these are particularly we call them mood stabilizer because we have seen that there are too much fluctuations in the mood. Sometime it goes up, sometime it goes down. We need, if you remember seeing that graph, we need euthymia instead of cyclic thymia, instead of ups and down into it. Like wavy structure, we want a proper stool, proper stabilized mood. So therefore we call it as a mood stabilizer. The most prominent, most oldest example of it is lithium, which is still being used. Other are valproate, which is basically anti-epileptic agents. Then carbamazepine, again anti-epileptic agent. Aripiprazole is antipsychotic. Olanzapine, quetiapine, risperidone, ziprasidone, these are currently approved for by this US FDAs for treatment of acute mania in bipolar disorders. Only lithium, then this sodium valproate, then aripiprazole, olanzapine, lamotrigine are approved for the maintenance of treatment, which is for continuous treatment of bipolar disorder. Quetiapine is the only monotherapy antipsychotic that is FDA approved for bipolar depression, while other all antipsychotic agents are used as a combination with lithium or such agents. Lithium is the drug of choice for bipolar disorder with euphoric mania. When the mania is euphoric, euphoria you must be knowing. Euphoria is very commonly or it is commonly defined as a false sense of well-being, false sense of well-being. So somebody feels that I am great, I am something, I am like that. So this type thing is known as a euphoria. So when it is a euphoric mania, lithium is the best drug, and valproate has a better efficacy for mixed states wherever both situations are there, whether it is mania plus or hypomania plus major depression, and like that when it is there. it is the best one, wherein irritable dysphoric mania is there, rapid cycling is there. So it is better in that as compared to lithium. Combination with lithium with other agents like valproate, carbamazepine, or lithium plus valproate plus the second generation antipsychotics can provide better acute response and long term prevention of relapse and recurrence than monotherapy in some of the bipolar patient, particularly those who are having mixed state or rapid cycling. So majority of these patients hospitalized for acute episode will be on combination therapy. So these are various drugs we can use, and we have various algorithms for that. You can see it. I'll just explain it. So what guidelines shows about acute maniac or mixed episodes, and if it is acute depressive episodes. Now, as I told you, it will be totally dependent on the diagnosis which has been done using various scales. So we are making the assessment for the situation whether there is any secondary cause of mania or mixed state is there, like presence of alcohol or other thing. We can discontinue the antidepressant if they are causing maniac phases. We'll taper off the stimulants and caffeine if possible. Then we shall treat the substance abuse, if any substance abuse. There are many, as I told you, marijuana, then heroin, and many such are there. Will encourage the good nutrition with regular protein and essential fatty acid intake, good exercise, adequate sleep, reduction in the step, and psychosocial therapy. These all things we have already seen that these are the things. In depression also we shall see similar thing. We shall try to avoid the problems. Only drugs which has resulted into depressive episode, they can be antipsychotics, benzodiazepines, or sedative hypnotic agents. They may lead to major depression. Again, here also we'll encourage good food, good diet, good sleep, stress reduction, and psychosocial therapies. So these things are common. Psychosocial therapy, it involves CBT, that is cognitive behavioral therapy, etc. So what treatment will be doing? That is, if it is a hypomania, will optimize the mood stabilizer, or it will initiate the mood stabilizing medication like lithium valproate, carbamazepine, or second generation antipsychotics. Then we can consider the adding of benzodiazepine for a short term adjunctive treatment, particularly for agitation or insomnia. Now they may have sleeplessness thing because of too much things are going. The mind is full with absurd thoughts. So in that we can give diazepam in that cases. Alternative medication treatment are oxcarbamazepine. And if response is inadequate to the first line treatment, then we'll go for a two drug combination, lithium plus an anticonvulsant like carbamazepine or this sodium valproate, and then we'll go for other one like it can be second generation antipsychotic agents, or it can be combination of anticonvulsant plus an anticonvulsant, or means two anticonvulsant, example carbamazepine plus valproate, but this can cause too much CNS depression, or second generation antipsychotic agent. So these are the treatment for hypomania. For mania, we'll go for in the beginning only 2 or 3 drug combination we can go, that is it can be lithium or valproate plus second generation antipsychotic. This one will be common, and it will be supported, or it will be added with a benzodiazepine like lorazepam or clonazepam, and along with that any antipsychotic for short term adjunctive treatment to reduce the agitation till the patient is hospitalized, or to reduce the insomnia, and lorazepam is recommended particularly for catatonia. Catatonia means decrease in the physical activities or less in the tone. Will not combine any antipsychotic, other antipsychotics. Already we have got for second generation antipsychotic. So simultaneously 2 antipsychotic will not be combining. Alternative medication treatment like carbamazepine, if patient does not respond to or tolerate oxcarbamazepine, can be there instead of carbamazepine. Then if still it is not useful, then in that case, if the response is inadequate, we will go for 3-drug combination like lithium plus anticonvulsant plus antipsychotic, or anticonvulsant plus an anticonvulsant plus antipsychotic. See, we are not combining 2 antipsychotic, this is clear, we already made it. And third, if response is still inadequate, then we will go for electroconvulsive therapy for mania with psychosis or catatonia, and will add clozapine for treatment which is refractory illness. Clozapine is found to be very good, clozapine and then aripiprazole. They are many times reserved for this kind of conditions. Clonazepine is found to be very good. Even in schizophrenia, we shall see this, that when other drugs are not working properly, then clozapine is preferred. Then mild to moderate depressive episodes, then we'll go for mood stabilizing medication, again lithium or quetiapine. Here alternative anticonvulsant like lamotrigine, valproate, antipsychotic like agents we can add, or along with fluoxetine or olanzapine combination. This we have seen in our earlier slide also, the first line treatment and second line treatment, if you remember. Then severe depressive episodes, then in that case we are having lithium plus lithium or quetiapine plus fluoxetine olanzapine combination, and do not combine antipsychotic, that is 2 antipsychotics we are not combining, we should not combine. There are many reasons for that. Many times particularly newer antipsychotics and older antipsychotic, if two combine, both two older, then the problem is both are through D2 receptor, if you remember pharmacology, and then it can have more chances of having extrapyramidal symptoms. If you combine one typical and one atypical, then at many times they may have conflicting mechanism of action, and then it can be making more problems. So therefore, because there are these newer or atypical antipsychotics or second generation antipsychotics, they have got multiple mechanisms of action. So as far as possible, we cannot combine them. Alternative anticonvulsants like lamotrigine, valproate can be added. If the response is adequate, we can add carbamazepine or carbamazepine or any antidepressant like maybe TCA or like that tricyclic antidepressant, or mitrazapine like agents. If still it is inadequate, then we will consider 3-drug combination, lithium plus lamotrigine plus antidepressant, or lithium plus quetiapine plus antidepressant. If still there is an inadequate response, then we will go for ECT treatment, which is refractory illness or depression with the psychosis or catatonia. So these are all various guidelines. This is how the algorithms are there for various mood episodes and bipolar disorders. Then next what we'll go for next class. By the time you please go through. If you have any difficulties, you can ask.